Our center is studying patients receiving CAR T-cell therapies, and these therapies are extremely effective with one infusion, producing long-term durable responses in nearly 50% of patients. Of course, the downside of it is that more than half of patients do not benefit from this therapy in a long term. And we wanted to find out what are the features of our CAR T-cells. Perhaps if there were populations of CAR T-cells that were associated with this prolonged durable response. We analyzed the cohort of 32 patients who received the FDA-approved CAR T-cell therapy called axi-cel. And we looked at peak expansion of the cells in the blood, because following infusions, they, of course, grow to very large numbers. And because the overall numbers of these cells did not correlate with the response in our cohort, we wanted to find out if there are certain subsets of these cells that do. And to do this, we collected high-dimensional single-cell proteomics data with CyTOF. We found that there are two subsets of CAR T cells at peak expansion, which is base 7 for axi-cel, that expressed CD57 and T-bet. And these populations were positive for granzyme B, which is a cytotoxic granule protein. They were associated with durable remission, which was really interesting for us. Because CD57 is, of course, an immunosenescent marker. So we wanted to understand these populations more. In addition, we found that another population of CAR T cells following infusion that expressed features of T regulatory cells was associated with poor response, but in the same time with less severe neurotoxicity. We would really like to continue monitoring these populations in patients receiving other CAR T-cell therapies, as well as our lymphoma patients receiving axi-cel CD19 targeted CAR at our center. And based on these observations, we may incorporate it into clinical monitoring and possibly even stratifying patients if they may need additional therapy quicker. In addition, T regulatory cells are, of course, immunosuppressive, and this suggests that our finding that patients with a large population of these cells have less severe neurotoxicity, but also worse response, makes sense, and suggests that we should potentially reduce this population at infusion if we find that it's present at infusion. And of course, we studied cells about a week following infusion in our patients. In our model agrees with some of the initial findings that infusing cells with a lot of proliferative potential and potentially quiescent cells is a good thing, because then the cells can expand rapidly following infusion. And this would, in our model, lead to rapid upregulation of CD57, which is, of course, a senescent marker. Whereas in infusion products, CD57 is not normally expressed. So our understanding supports a model in which tracking this CD57 expressing T-bet positive CAR T cells in blood of patients allows us to appreciate true measure of clonal expansion in a patient, whereas just counting CAR T cells in blood may not quite capture the full picture, as the cells may be located in my tissue or in lymph nodes where they are supposed to go in lymphoma.